And I just want to frame this as something that's really important and material for Pacific Health. So we mentioned earlier the life expectancy gap, and for Pacific peoples that's more than 6 years, and if you take the northern region it's actually 7 years. And within that life expectancy gap, the top 10 causes that contribute to that, well, the first actually now is diabetes, which contributes 0.8 years to that life expectancy gap. But the next biggest gap, 0.7, so it's a very fine run race, is actually coronary disease. And we know there are entrenched inequities in pathways. We know there are issues with access. So this piece of work is a really important piece of work at a system level for Pacific Health. And so we would like to invite to the podium right now some very preeminent people. So I'll just mention that the research is actually called Designing Heart Health Services to Achieve Māori and Pacific Health Equity. And I'd like to welcome to the podium Corina Grey, Karen Brewer, Sandra Hanchard, Taria Tane, Rochelle, Ellison-Lupena, Taueetia-Su'a. Welcome.
Thank you very much for the lovely welcome. Tēnā koutou katoa, talofa lava, whakalofalahi atu, ma loelele, kia orana, nisa bolavanaka, and very warm greetings to you all. I'm sorry that we're the last. We'll try to make it high energy, but it is my great privilege to be able to present to you on Manuataki Whatu, which is a 3-year research program, and I'm very privileged to be presenting alongside 5 of my colleagues. And I would also like to acknowledge my co-principal investigator, Associate Professor Martiri Harwood, who unfortunately is unable to be here today, but sends her aroha and very best wishes. I would also like to acknowledge all of the people on this slide who have been absolutely integral to the success of our program. Manuataki Whatu is a diverse and wide-ranging research program that has focused on the full spectrum of heart health services, and it has been able to do this because of the diverse membership and expertise of our team. It is a research program that has been built on a foundation of Māori and Pacific co-leadership and a strong commitment to developing, nurturing and growing Māori and Pacific researchers. Our team includes Māori, Samoan, Tongan, Cook Island, Niuean, Pākehā and Sri Lankan researchers at many different stages of their careers, all of whom are absolutely committed to amplifying the aspirations, needs and voices of Māori and Pacific whānau throughout Aotearoa. Not only are our cultural and ethnic backgrounds diverse, but so too are our professional backgrounds, enabling us to investigate heart health equity through a myriad of lenses, which I believe has been one of the key strengths of our program. Our team includes kaupapa Māori and Pacific researchers, epidemiologists, IDI researchers, public health and primary care physicians, nurses, paramedics, a pharmacist, a speech-language therapist and a communication specialist. Throughout our program, we've been privileged to build partnerships and collaborations with other organisations and healthcare practitioners, and in particular, I'd like to acknowledge Associate Professor Bridget Dicker and our other collaborators from Hatohone St John Ambulance. I'm very delighted to start off this presentation by giving you a little bit of background about our research and then presenting some of the key findings from our quantitative research arm. We were just talking about it earlier, and we will eventually put together a symposium based on all our research, but we're just kind of giving you a snapshot of what we've done over the last 3 years. We will showcase some of our amazing talent. So Dr. Karen Brewer will talk about our qualitative research findings. Dr. Sandra Hanchard will talk about our co-design workshops and her fellowship, which is focused on equity and discharge planning for heart failure. Then we have 2 of our PhD students, Taria Tane and Rochelle Newport, who will talk about their experiences on the program. And then we'll finish with Dr. Taueetia-Su'a, who will discuss how we engage with Pacific participants. So, thank you, Karen. Public health people think alike, I think. But Karen has already presented to you about life expectancy. And this is just, this graph is just, I guess, showing another way that Karen talked to you about, the life expectancy gap. So this graph shows you life expectancy over the last 20 years in Aotearoa for Māori, Pacific, Asian and European people. So as you can see, by and large, life expectancy is increasing, which is a really good thing. Everyone is living longer. But unfortunately, we have that stubborn life expectancy gap for Māori and Pacific people. And as Karen has already pointed out, what is particularly worrying is that the life expectancy gap has not changed at all for Pacific people. And in fact, if you look at the graph, Pacific life expectancy hasn't really changed since 2010. It's quite static. And this is really the why of our research. So, as Markerita has said, cardiovascular disease contributes almost a year of the 6-year life expectancy gap for Māori and Pacific people. But it's a condition that we know can be prevented and treated with low cost and effective medications. But what studies have shown is that Māori and Pacific people disproportionately experience challenges accessing care and in many cases are less likely than other population groups to receive these evidence-based treatments. However, how big those gaps in treatment are, where along the spectrum of care they occur, and how people in whānau experience that care has not been well studied. This is a gap in our knowledge that our research aimed to address. So in 2019, when Healthier Lives and the Heart Foundation announced joint funding for a 3-year program of research focused on heart health equity for Māori and Pacific people, we were really excited. We saw this as an incredible opportunity to put a spotlight on the specific role of health services in achieving equity in heart health, a way for us to systematically address knowledge gaps in this area, join up research and work that was currently being done on improving heart health service, but ensure that there was a particular focus on equity. And really importantly, use this as a platform to attract and support more Māori and Pacific researchers in heart health. So the purpose of our research was to identify evidence practice gaps along the entire continuum of care that could be addressed to improve heart health outcomes for Māori and Pacific people. And when we talk about the continuum of care, we mean from pre-hospital paramedic care right through to hospital care and discharge back to general practice and primary care. So there were 3 phases of our research program. In the first phase, we held a national hui to bring together different providers and researchers working in heart health care to find out what people were already doing and to forge collaborations. And this really enabled us to strengthen our relationships with organisations such as Pūtahi Manawa, the Heart Health Centre of Research Excellence, the Heart Foundation, and I'd like to acknowledge you, Clive, thank you very much for coming, Cardiac Clinical Networks, and I'd like to acknowledge Dr. Mayana Lund for being here today, and the Cardiac Society of Australia and New Zealand, as well as other Māori and Pacific heart healthcare workers. The first phase also involved systematic reviews to identify what was already known and, in most cases, not known about equity for Māori and Pacific people in relation to heart failure, cardiovascular risk assessment in primary care, and access to pre-hospital care after an acute cardiac event in the community. The second phase involved using both quantitative and qualitative methodologies to identify gaps in these areas and capture the stories and experiences of patients in whānau who had accessed health services for a heart-related condition or event, as well as the perspectives of the diverse health providers involved in their care. In this way, we wanted to capture not only the what, when and where of current health services, but also the why and how of why things are the way they are through the lenses of people accessing the system and also those within the system. So our program is currently in phase 3, which involves a series of 4 workshops across the country with patients, whānau and healthcare providers to bring together what we've already learned through the first 2 phases and co-design what we can do to ensure health services meet and ideally exceed their needs and aspirations. The final output of this phase is the development of a quality improvement equity roadmap that will support services and the system to progress from current state to where patients, whānau and providers have identified where we want to be appropriate, accessible, timely and high quality health services where and when whānau need them. So stay tuned for that equity roadmap. So when we first started this program back in 2020, we got a lot of people coming to us and saying, hey, we want to collaborate with you. Hey, we want to do this. We think this is really interesting. So right at the beginning, Markerita and I thought it was really important that we sit down and establish some principles to help guide our research and guide the decisions that we would make. And so our team have come up with these guiding principles that we've used from the start, and these are based on the points of the Māori Star Compass. So, rā, research excellence; kāinga, valuing Māori and Pacific knowledge; ngoi, making sure that all our approaches were strengths and resiliency based; manu, making sure that our research was action driven; ngā rangi, optimising workforce development opportunities and being collaborative; ngā reo, being whānau centred; and haka, ensuring there was an optimal balance of quantitative and qualitative approaches. So what I want to do now is take you through a very quick whistle-stop tour of some of our quantitative findings, and then I'll hand over to Karen, who will talk about our qualitative findings. This table here is from Rochelle Newport's PhD, and Rochelle will speak later about some of her other findings. So Rochelle was focused on pre-hospital care for a cardiac event, and in this study she linked national ambulance data with national hospitalisation data to identify all adults who were hospitalised with an acute cardiac event between July 2019 and June 2021. Using this data, she calculated the age-standardised incidence of acute cardiac events that were hospitalised and found that Māori, and in particular Pacific, men and women were twice as likely as non-Māori, non-Pacific people to experience an event. Using the same cohort, Rochelle found that Māori and Pacific people experiencing an event were 10 years younger on average than non-Māori, non-Pacific people. And whether or not they lived in a rural or urban area, Māori and Pacific people were less likely to use an ambulance to get to hospital. Now, this is really important because time is of the essence following an acute cardiac event, where a delay of only a few minutes could be the difference between life and death. And so here is a prime opportunity to do care better and address a known equity gap. And this is exactly what we're doing, currently working with our collaborators from Whatu Ora St John to identify ways we can ensure people are able to access ambulance services when needed. Our primary care analyses were led by Vanessa Selak and Janine Painter, and using IDI data, we identified all people resident in New Zealand aged 30 to 74 who had contact with the health system. From this, we identified people with cardiovascular disease, diabetes, or both, and compared the age-standardised prevalence of diabetes and cardiovascular disease among different groups. So we found that Māori had the highest prevalence of cardiovascular disease on its own, 4.1%, with another 2.2% with cardiovascular disease and diabetes, and that Indian and Pacific people had the highest prevalence of diabetes, both on its own and in conjunction with cardiovascular disease. So the prevalence of diabetes in these groups was approximately 14%, with another 3% who had co-prevalent cardiovascular disease and diabetes. If you contrast this with Europeans, 3% had diabetes on its own, and less than 1% had co-prevalent cardiovascular disease and diabetes. So the burden of cardiovascular disease and diabetes firmly rests with Māori, Pacific and Indian people. However, if you look at what care people receive, this looks a little bit different. So we were fortunate to get access to laboratory testing results data in the entire Northland and Auckland regions and investigated who had received a cardiovascular risk assessment. We found that Indian men and women had the highest rates of cardiovascular risk assessment, approximately 80%, which is still not as high as we would like, but still higher than other groups. So this is good news for Indian men and women, given how high their diabetes and cardiovascular burden is. However, the same cannot be said for Pacific and Māori, men in particular. Only about 2/3 of eligible Māori, Pacific and European men and women had received cardiovascular risk assessment, which again is another gap in care that we should be addressing. And of course, this is just cardiovascular risk assessment. What we really want to get to is that people are being managed on medications effectively. And we know from previous studies that this is not happening. We also have another PhD student, Julie Winter-Smith, who is using IDI data to look at the prevalence of cardiovascular disease among Pacific-specific ethnic groups. What we know is that Pacific is an umbrella term to describe 16 diverse groups in New Zealand, and there has been very little research looking at the epidemiology of cardiovascular disease in these groups. So Julie used the IDI to examine the percentage of people aged 30 to 74 living with heart disease at the time of the 2013 census, and she had to use the 2013 census because she was also looking at country of birth, and unfortunately the 2018 census had such a low response rate that the data quality was really poor. So if you can see from this graph here, Cook Island Māori had much higher rates of cardiovascular disease than other Pacific groups. And this is important for us to be able to tailor our approaches accordingly. Finally, one of our master's students, Ainsley Laumatea, looked at Māori and Pacific representation in the heart health workforce, and we know there's a large body of evidence showing that health outcomes can be improved when people have the choice to see healthcare workers from similar ethnic, cultural and linguistic backgrounds. In this table, Ainsley's research shows that Māori make up about 17% of the total population and Pacific people around 9%. But if you look across here, none of the disciplines are currently even close to achieving representativeness in these groups. Apparently, we have 3 Māori cardiologists and 1 Pacific cardiologist in the whole of New Zealand. This is something we really need to address. And speaking of workforce development, one of my favourite things about this entire research program is just being able to work with some amazing women, Māori and Pacific women, and just seeing them flourish over the last 3 years. So our program has included 3 senior research fellows, 4 PhD students and 2 master's students. Workforce development was one of our key success indicators. It wasn't at all publications, but we've already published 13 peer-reviewed publications. There's 1 in submission, 4 in development and 2 planned. And a lot of these have been led by our PhD students. We've also presented at 25 different conferences, and I just feel really proud of them. So I will hand over to Karen very soon, but just to highlight, Karen Brewer has recently left us because she is now co-director of Pūtahi Manawa, the Heart Health Centre of Research Excellence. Dr. Sandra Hanchard was the inaugural recipient of the Heart Foundation's Pacific Research Fellowship in 2022. Julie Winter-Smith and Rochelle Newport have both submitted their PhDs last year. And 2 of our master's students, Ainsley Laumatea, who's a public health registrar, and Sarah Penny, who's a paramedic and also a lecturer in paramedicine, have also got their masters. So we feel very proud of them, and I'd like to hand over to Karen and the rest of the team. Thank you.
Look at that. O kia ora koutou. I'm the speech language therapist in the group, and I met another speech language therapist here today. So here's to transferable skills that we learn in our degrees. And yeah, just following on from what Corina said, when I got appointed the co-director Māori of Pūtahi Manawa late last year, I'm absolutely certain I would not be doing that job now if it wasn't for my experience in Manamataki Whatu. So good for me personally. I think good for the general Māori research workforce development as well. So yeah, mihi to Healthier Lives and the National Heart Foundation for what this has done for the workforce development. talk a little bit about our qualitative interviews. We've had qualitative studies. We've got 2 studies that we are sort of integrating. The first one involves interviews with 61 Māori and Pacific patients and whānau. The day of our very first interview, Corina and I were on the phone as I was about to head there, and that was the day Auckland went into that massively long lockdown. So the majority of them were done via Zoom and by phone, and by Tua frantically working in Wellington because she wasn't locked down like the rest of us. So these people had experiences of cardiovascular risk assessments, acute coronary syndromes or heart failure, the same as the 3 areas of our foundation projects. And then we had the focus groups and interviews with 23 healthcare providers. There were focus groups of cardiologists and of Whatu Ora staff, and interviews with GPs, nurses and funders. We made sure to get a mix of participants there who were Māori, Pacific and non-Māori, non-Pacific people, and also working for specific kaupapa organisations as well as mainstream healthcare providers. The question that we were asking, the research question for these qualitative studies, was what are the reasons behind evidence practice gaps and inequities in cardiovascular care for Māori and Pacific people, as evidenced by the experiences and perspectives of patients and their families, and from the perspectives of health service providers. The results of our patients and whānau interviews, I'm just responding to reviewers' comments about that manuscript at the moment, so it's getting there. They came into 5 themes. So the context is about everyone coming with their own story and how it's important for healthcare providers to recognise the patient and whānau context. Mana is about how the heart, the manawa, is the most important thing because, as one of Rochelle's participants said, it holds the mana of our time and place, our wā. Healthcare should uphold the mana and dignity of the patient and whānau. The condition is people want to understand their condition and its management, and to achieve this there needs to be good reciprocal communication in a language and style that is accessible. People is about all the different people who are involved in the healthcare journey and the influences of those people. It also includes some of the healthcare providers, whānau members, community members, different champions, and also the importance of culturally safe service provision. Finally, the journey. While the health system tends to focus on outputs and outcomes, participants felt that the healthcare journey from getting in, which was difficult, to staying in, that whole journey was just as important to them as the outcome. These are a few quotes from our participants that cover probably most of those themes. So in the context, Peter talked about, I continue to work as my family needs come first. The staying home wife, the children at school, the cost of living. My health continues to deteriorate as I struggle on. And there are many similar quotes to that. There was mana included the sort of spiritual aspects of heart health, which a lot of people brought up, including Penny, who talked about how I know it's a miracle for me to still be alive. There was a sense of being on borrowed time for lots of people. Bibi talked about having to fight the system all the time. And Fred asked, is it because we're Pacific Islanders that we go to the bottom of the chain? And for Taria, she lost her brother to some kind of acute heart event. And his partner tried to resuscitate him. They called the emergency services, but they actually took over 3/4 of an hour to get there. So something with the demographics didn't sit well for us as far geographically. That was Taria's take on it. So lots of different struggles that people experienced. I've got this photo here. This was Te Whare Tukutuku, which is a group of Māori and Pacific heart health providers that assembled at the Cardiac Society, well, at the time of the Cardiac Society conference last year. Because I think this is a really important point. Māori and Pacific healthcare providers came out as vitally important, both in the whānau interviews and in the provider interviews. So patients and whānau spoke about the positive impact that Māori and Pacific staff had on their healthcare experience just by being there and being themselves. And also the loneliness they felt when, as one person said, there's no one like me here. And in the provider interviews, as we analysed the kōrero, which we're still finalising now, it was very clear that Māori and Pacific individual clinicians had a greater insight into the context, into the lives of their patients, and therefore were able to better relate and tailor the care. And also that working within kaupapa Māori and Whatu Pasifika organisations enabled them to act in this way more so than in the mainstream organisations. With that, I will pass over to Sandra.
Tēnā koutou mai lelei. Now, I'm usually the person who makes the cup of teas, organises the meetings. I'm the mother hen of Manuataki Whatu, but just a mihi to Tere and Corina for always lifting us up. They're our platform, our wings. So it's been quite a journey being part of Manuataki Whatu. It's been an amazing journey, and as Corina mentioned, we are now pulling together all these threads, trying to make sense of this data, the whakaaro that's come together to come up with a roadmap, solutions. We've had lots of robust discussion this morning about sustainability and doing it right. We've got very strong guiding principles that we refer to: reciprocity, mana enhancing spaces. So what we're doing this time is we're bringing patients, whānau and providers into the same space. A little bit nervous about that, but we are very conscious to make that place a safe space. And what Viliami was saying this morning about being caring, that's just really a key part of who we are. And what we think we're going to try to do with these co-design workshops is just to strengthen the relationships between the providers, the people, the whānau, so that they can keep working on it together. So these are some of the questions that we're posing. What does good heart health services look like and feel? What's going to work best for you? And how can we improve the patient journey from both the whānau and the people who are at the coalface of doing the mahi? So thank you to the Heart Foundation, Putahi Manawa, for this Pacific Fellowship. And this project came about through discussions with cardiologists, heart failure nurses, who I love. They do amazing work. And what we've heard from whānau in terms of, you leave hospital and you get this pretty awful piece of paper that's got lots of information, medications, not useful to anyone really. So there's a lot of ways that it can be improved. I come from an information and communications background, so trying to bring in a slightly different lens to how we can improve that. But really what we're trying to seek is for patients to be connected to healthcare. I really don't like the word discharge planning because you're being discharged. So what should it mean? It should mean the transfer of care, from one provider to the next. We spoke to one kaitiaki who said that he actually drives the patient to the GP. He will actually take them to the GP to make sure that there's not that gap in care. What else have we heard? We've heard about Māori and Pacific more likely to go through general medicine departments rather than cardiology, and then what are the implications there for inequitable care. I'm personally invested in this mahi, my own kaimahi, my own family, kainga, people dying 10 years younger than they should be. And I asked my mum for a proverb today. So, whola e whala kai tailanga e kainga. So as everyone comes together, they share their contributions for ngāwe, for work, for enhanced results. And I think there's quite a strong message for the health system. You know, we hear lots of stressed out providers, not trying to be too pointed, but sometimes there's cultures of blame because people are stressed out. So we're trying to do so much with so little, and just drawing on my Tongan knowledge, you know, we work together to do what we can for the whānau that we serve. So, māloa pito, and I'd like to pass it on to Taria Tane.
Tēnā koutou, ko Taria Tane tōku ingoa, ko te roroa me ngā puhi, ngā iwi, no kaipara ahau. So kia ora everyone, my name's Taria. I'm one of the doctoral students under the Manawataki Whatu project. I feel like I'm probably going to just be a bit of a hype girl for the team here today. So I'm going to spend 5 minutes just talking about what the Manawataki Whatu project and team means to me. But first off, my doctoral research project. So I'm looking at how we can improve access to care for rural Māori. I live and I was raised in a rural community way up north at the top of the country. So it is a sort of topic that's close to home for me. I was asked to spend a few minutes speaking about what Manawataki Whatu means to me, and these three words kind of instantly popped into my mind. So I'm going to start with community, as this is probably the most significant taonga or gift that was given to me through the Manawataki Whatu team. So I'm supported by my amazing supervisory team, which consists of Martire and Vanessa, and also Kyle Eagleton, who is a rural health researcher from up north as well. I also get to connect with Shanti from the team every month for mentoring sessions, which kind of turn into counselling sessions as well. And I also met with the entire research team on a monthly basis as well. So for me, doing my PhD rurally, it can be a bit isolating, a bit lonely, so it's really helpful for me to have a whole team of people outside or alongside my supervisors that I can connect with on a regular basis and reach out to if I need support with anything. Alongside that, we also had a student support group earlier on in the piece when we were all starting out on our sort of journeys, undertaking our studies. And we would get together and meet every month or so and connect and share any sort of learnings and challenges with each other, that we were going through and experiencing. And these hui were also supported by Shanti from the team as well. So it's awesome now we're further along in our journey. Some of us have finished and we've built these really strong relationships with each other, and it really does feel like we are one big whānau. So the sense of community that the team has provided has been really important in making me feel supported on my doctoral journey. So the next one is growth. So in terms of growth, some of us would know how challenging undertaking a PhD is. It's by far the most challenging thing career-wise that I have done. It's pushed me far outside my comfort zone, and it's helped me grow both professionally and personally. So being part of this particular heart health kaupapa has really grounded me in knowing what it is I want to do, and also the whānau and communities that I want to spend my time supporting. Although I'm very much looking forward to completing my PhD, I'm really grateful for the growth that I've had over the last 2 years, and that never would have happened if Martire and Vanessa hadn't shoulder tapped me and seen potential in me to do this mahi. And lastly, opportunities. So thanks to the connections from the Manawataki Whatu team, I've been really privileged to be able to undertake some really amazing training and development opportunities. From attending the Pūtahi Manawa Heart Health Forums for emerging researchers over the past 2 years, to travelling over to Canada last year to take part in the Tutor PhD transdisciplinary research training in primary health care. And another one of our Manawataki Whatu students, Jess Hutchings, is taking part in the Tutor program this year. So that's pretty exciting. So these are just a couple of examples of the opportunities that not only myself but other students in our group have been able to take part in. that's all I wanted to say. I just feel pretty lucky to be part of the Manawa Taki Whatu whānau, and I think the emphasis on workforce development has resulted in many doors being opened for us emerging Pacific and Māori researchers, and allows a sort of wider scope of research practice. And because of this wider scope, we have more potential to improve heart health outcomes for our whānaus and our communities. So thank you. Kia ora. I'm going to hand over to Rochelle.
Kia ora koutou. Ko Rochelle, Ellison-Lupena, tōku ingoa. Ai te taha o tōku pāpā no Ngāti Parau, Ngāti Whakaue, Ngāti Mutunga, me Kaitahu Hoki, te taha o tōku whaia no Rarotonga me Mangaia. I submitted in the first days of December, so early December, and this is the first time I've presented on my research, and I'm really nervous because there's some really fancy people in the audience. So forgive me if my emotions are close to the surface. I'm still traumatised by doing my PhD. So Corina's already talked a little bit about the quantitative findings, and part of my research I was really keen to ensure that we also had a qualitative lens to what I was looking at. The statistics that we had, I was grateful to be given from, have access to from Hatuhone and Wellington Free, included my whānau. So, at the surface. So, it was important that I had space for whānau to share what that actually looks like for them. I'm good. See, support everywhere. So I'm just going to talk a little bit about the qualitative findings. And to be fair, nothing that I found we don't already know. And it just reaffirmed that there's lots of things. We know that this is a problem. Where's the effort to fix it? Where is the input to fix it? And how can we address some of these things? So essentially, whānau experience barriers to accessing acute care in the community, and that those barriers are persistent. And despite those barriers, whānau are actively engaged in trying to seek care. So, as was in the wider study, they're reporting it as like a fight. They're fighting to be engaged, it's a battle, and that is apparent in the way that they describe their journey. So I was focused on the acute portion, the acute care in the community, but actually our whānau don't see their journey as siloed as we tend to do it in the health system. So they talked about it as a holistic experience from calling an ambulance or not to being discharged and the care that wraps around them post-event. All of the participants that I spoke to described experiencing structural and interpersonal racism, every single one of them, at varying degrees. They might not have labelled it that, but that's what those experiences were. And that was from ambulance through to the specialists, back to the post-discharge care provision. And one of the things that they were one of the things that they were consistently focused on was, once they've had their event, what happens to them afterwards. And often that post-care provision is inefficient, inappropriate and insufficient. So we had whānau who went to their I've had a heart attack support group that they take them to. The clinician talked to them, and as a part of those conversations, they realised that every single other person in the room received a treatment that they didn't get. And so they were the only Māori. And so if you were sitting in that room, that's not the sort of stories that we want to have. Okay, so lots of whānau talked about some really tough experiences. The system is clearly not working for us, and that system starts from out of hospital through to discharge. But they are also very focused on what can we do to address this. And there's some things that I would think of like as a quick win, and that is ensuring that we have improved access to community defibrillation. And lots of whānau talked about not having one. Whānau talked about not having a defibrillator present in anywhere, not even on the ambulance that came. Well, not the ambulance, they were rural, so on the first responder that came, they didn't have defibrillators. Having better access to CPR training, and that having that CPR training be tailored to fit their needs or our needs. And I know that Hatuhone is working on that currently, so that's exciting. And those are the kind of things that I think of as a quick win. There's something that we could quite easily invest a bit of money in and ensure that we have defibrillators located in places that we need them. A big thing, I think, is that despite Eri Hapiti Ramsden's push for cultural safety in our health workforce, it's not filtering through necessarily, and that lots of our whānau report having very difficult interactions with their healthcare provider. And that when you have a healthcare provider who treated you with dignity and respect, often it was their GP, it really helped the process. So ensuring that we have a fit-for-purpose health workforce, I think, is an important consideration. And part of that kind of cultural safety is that the information that people are provided once they're kind of journeying through care isn't always enough. And so lots of them reported having a desire for better information that is given to them in a way that's accessible and that they can implement some of the recommendations that they've been given. And finally, a lot of one of the suggested ways that we could tailor our interventions is actually to ensure that rongoā in all its forms is present, and thinking outside of the box of how we enable whānau to access that. So you can, when you're in hospital, it's quite easy to see a chaplain, but if you wanted a kai karakia, unless you knew someone in your whānau who can carry that, there's no access. So how do we ensure that some of those other modalities of healing are available? And I'm going to step away now because, and I think Tua.
Oh, I'm the last. Is that right? Okay. I'm called the kuia or the kaumatua of the team. I'm here today just to talk about. Oh, where's this thing? Yeah, see, the young ones can do it better. Okay. There's a long list of actions that enhances the engagement of Pacific communities, but I will just bring forth today because it's a long day. So the first one is having strong networks or building good relationships with the people, with the community that you are. So when I was first approached to be part of the group, so I was the one that was ringing everybody, every direction, and we managed to actually build a good number of people to participate in the study. So Pacific peoples are associated with churches and their own ethnic organizations, and they become the hubs or the place, and they call it their village, if you like. That's how they get connected. And those are the places that we go to when you want participants to be involved. And being able to have strong connections with our own families, we start with our families. And then our community, it actually increases finding people. It's not what you know, it's who you know. that actually connect to who actually is going to be willing to be part of the study. So several participants in our study also heard it through the Samoan radio. After I had to present, I had to do something first before I have to ask why the reason why I went there. So several participants in our study heard it through the Samoan radio after presenting a heart health education session for a whole hour before I actually say what I had to do. And because many people were actually ringing in because they heard Tua. Tua has been in Wellington for too long, so they could hear me. The good thing about the Samoan radio is actually the Tokelauans actually listen to this radio. So I was able to speak in Samoan and still being able to reach some more people. So the second one is clear communication. Face-to-face works better. When you hear about the COVID time, I was on the phone, and then they suggest Zoom, and they said, many Pacific people don't own a laptop, so how can they Zoom in if they don't have it? So, but we found a way. So it was good because by the time we did the interviews, we were actually going off all the tight regulations at the time. It is recommended to utilize an interpreter or translator. As you know, we had mixed people. So Pacific, I don't like this word Pacific Islanders. If you know Wint, who actually say he is an author, Albert Wint, yeah, who actually said, don't call us Pacific Islanders, call me Samoan or call someone Tongan, and not call us Pacific Islands. So I try and say, we are from the Pacific nations. I try and do that, but because everything is written island, I have to do it. So when you think about offering Pacific languages, we had people that were able to speak in Tongan, that were able to speak to their own people. And there was more that you can talk about when you're actually communicating in your own language than having everything in English. English is my third language. So, and Samoan, they call it a heavenly language. It didn't catch her. Anyway, so finding different ways in building relationships, you have to do that. Otherwise, you cannot get the people that you want. So the connections are very important. And when you talk to people, make sure there's a translator, or even finding somebody that's actually a key person or a paramount leader within that community to take you, to mentor you, to actually help you. Otherwise, they won't open their doors to you. So the third one is cultural and spiritual values. Acknowledging the cultural and spiritual values actually help access homes and communities. It is recommended to be conscious of what you dress, how you dress, shoes off before entering, you know, all the cues when you go into their homes, and be guided with what they would like you to do. Offering a prayer can actually set the scene, but don't expect everyone to ask for a prayer. If they don't ask for a prayer, don't do a prayer. Or else, he said, are you here to, yeah. Anyway, so you just do, you actually, when you go in, look for cues and don't just go and do your schedule. You know, I'm here to do this, I'm here to do that. So please do not be like someone that would just come with a piece of paper, ask questions, and go away. People tend to actually talk about where they're from, how they were brought up in the islands or in their nation. And if you allow them to talk, it tells them or shows them that you respect and you care for them. If you try and get to your sentence and your questions, they will not tell you anything. So you'll just walk away, probably only a piece of paper half filled. It is also known that there is a profound spiritual connection with Christianity as well as in the natural world. Their ancestral lineage and the nation they belong, and that is the center of their cultural identity. And that's what you have to treasure when you go in. And respect and reciprocity, fa'aloalo. respect. You will be welcomed in any Pacific home if you show respect. It is pivotal that it's a two-way transaction, if you like. It's not just you asking questions. They are also there to tell their story. Not necessarily what you want to hear, but you've got to have time. Don't just expect that you're just going to get everything from them in just one question. For example, the participant wanted to know more about their own conditions and what they should do. And that is what, when I arrived, they didn't care about what I wanted to get. They said, I know you were my nurse, so please tell me, what's this and what's that and what's this? So I had to explain, start from the beginning, how the heart works, and then what is a heart attack? And then they say, what can I do to prevent the next event? How can we go through when we go to the health, to the hospitals? So all those things you have to make time. I heard Dr. Williami this morning say, time is nothing to us. We have to have more time. And having me, and the last time, I just talk whenever I finish. So as a nurse, I had to do all those things. And, by the time I'll be there, probably there for half an hour or even an hour, I still haven't started. So you've got to allow time. And I say that is reciprocity. It's not just a core heart that you give. It's your time. It's your heart. And you're there in their space and their time. And sometimes I come out crying because they'll tell me a story about someone who died, someone who is this and who's that. And they say you're actually doing counseling at the same time when you see people. But that's how we approach our people. I can't explain everything today, as I say. You'll be here by midnight if I talk to you about it. So thank you. I know Corina sits there, and I say to Corina, yeah, I'm your mama, or am I your auntie? She said, no, I'm a sister. And I said, no, you look at me, and I know you're too young.
I love that she calls me young.
Thank you so much for having me.
So I hope through the different presentations you can see how diverse our research program has been, and how much we've learned from each other. We have messages to the future, but I'd really like to extend a very heartfelt thanks to Healthier Lives, to Jim, to Sir Jerry, to Jean and the rest of the team for this amazing opportunity. I hope you can see that through this funding that you've given us, we've really been able to grow a cohort of emerging Māori and Pacific researchers. So thank you very much, Whakatau Lava.